Sickle cell anemia. It is an example of autosomal recessive disorder, caused by a point mutation in the 6th codon of B globin that leads to the replacement of a glutamate residue with a valine residue. HBS provides protection against falciparum malaria endemic areas. Two scenarios to explain these observations are favored. Metabolically active intracellular parasites consume oxygen and intracellular pH, both of which promote hemoglobin sickling in as red cells, cleared rapidly by spleen. It impairs the formation of membrane knobs containing a protein made by the parasite called FEMP1 associated with cerebral malaria. Pathogenesis. The major pathologic manifestations chronic hemolysis, microvascular occlusions, and tissue damage all stem from the tendency of HBS molecules to stack into polymers when deoxygenated. Sickling causes cumulative damage to red cells through several mechanisms. As HBS polymers grow, they herniate through the membrane skeleton and project from the cell's head by only the lipid bilayer. Dehydration. Severe derangement in membrane structure causes the influx of Ca2+ ions, which induce the cross-linking of membrane proteins and activate an ion channel that permits the efflux of K+ and water. Both extravascular and intravascular hemolysis occurs dependent upon more subtle red cell membrane damage and local factors, such as inflammation or vasoconstriction, that tend to slow or arrest the movement of red cells through microvascular beds. Pathogenesis of the microvascular occlusions, which are responsible for the most serious clinical features. Sickle red cells express higher than normal levels of adhesion molecules and are sticky. The stagnation of red cells within inflamed vascular beds results in extended exposure to low oxygen tension, sickling, and vascular obstruction. Free hemoglobin released from lysed sickle cells can bind and inactivate nitrous oxide, thus platelet aggregation happens, enhancing stasis and sickling. Morphology. The peripheral blood demonstrates variable numbers of irreversibly sickled cells reticulocytosis, and target cells, which result from red cell dehydration. Powell-Jolly bodies in some red cells due to the asplenia. The bone marrow is hyperplastic as a result of a compensatory erythroid hyperplasia. Expansion of the marrow leads to bone resorption and secondary new bone formation, resulting in prominent cheekbones and changes in the skull that resemble a crew cut on X-ray studies. Chronic erythrostasis leads to splenic infarction, fibrosis, and progressive shrinkage. By adolescence or early adulthood only a small nubbin of fibrous splenic tissue is left. This process is called autosplenectomy. Clinical features. Age. Majority 3 months to 1 year of life. Hyperbilirubinemia. Spleen. Decrease in size due to vasoocclusion. Leg ulcers. Hand-foot syndrome, dactylitis of bones of hands or feet or both, infections associated with SCA, children pneumonia and meningitis. Osteomyelitis due to salmonella, typhi. Adult, repeated bone infarcts due to increased frequency of osteomyelitis. Gallstones, cardiomegaly, priapism, retinopathy, stroke. Crisis in sickle cell syndromes. Sickling crisis, vasoocclusive crisis, precipitated by fever, infection, dehydration. Blockage of microcirculation, abdominal, bone, chest pain. Hemolytic crisis, decrease in HB, jaundice, reticulocytosis. Aplastic crisis, parvovirus B19 causing a transient cessation of erythropoiesis. Sequestration crisis, occurs in children, splenomegaly, hypovolemic shock.